Good day. Today we will be discussing the module on heart failure. We start off with a review of the mechanism of cardiac contraction and relaxation based on the ultrastructure of the myocardium. On this diagram, you can review how the stimulation or electrical excitation allows the teeth tubules to let the calcium channels open, and where the entrance of the calcium now starts the process of contraction and relaxation. This further allows the calcium to interact with troponin C, which now removes the inhibition that is exerted by troponin I, allowing the cross-bridge cycling to occur, which is how the actin and the myosin slide over each other. And from that ultrastructure, we review the cardiac cycle. There are three basic events within this cycle. LV, or left ventricular contraction, is involved in systole, consisting of two activities, the isovolumic contraction and maximal ejection phases. Then the start of the diastole, as the left ventricle relaxes with reduced ejection and isovolumic relaxation, followed by left ventricular filling event. So in this, you have the first phase, which is the rapid filling phase, and then the slow left ventricular filling phase towards the end of the diastole, and then the atrial systole, or the booster phase, which adds about 20% of the total volume that is in the left ventricle before it is ejected. For the myocardial mechanical performance, we have at least three determinants. First of which is the Frank-Starling mechanism. This is an old statement made by Frank and Starling, which involves the volume within the heart during diastole, such that with greater volume, there will be greater energy of its contraction. There was another statement that was incorporated into this from the diastolic stretch made by Frank, where he stated that when there is an increase in the stroke volume, that diastolic stretch increases the contractility, which we call the positive inotropic effect, such that the greater the initial volume, the more rapid the rate of rise, and the greater the peak pressure that is reached, so that there will be also a faster rate of relaxation. It will be like stretching a rubber band, a new rubber band. The greater the stretch, the faster the peak pressure is reached, and the faster the rate of relaxation as it is released. The second determinant of myocardial mechanical performance is contractility. So this is the inherent capacity of the myocardium to contract, which is independent of the changes in preload and or the afterload. So we understand preload as that load present before the left ventricle contracts or at the end of diastole. So this reflects the venous filling pressure in the left atrium, which in turn fills the left ventricle during diastole. While afterload is that amount of load or pressure, however you call it, after it has started to contract. So it may be the systemic pressure that adds to the afterload, or the aortic valve, its ability to open up as the left ventricle contracts. In the non-failing heart, the left ventricle will be able to overcome any physiological increase in load. We also mention here wall stress. This also is involved in the changes of the left ventricle with any change in load. So if you notice, wall stress is pressure times the radius of that chamber over the wall thickness. So any increase in the size of the left ventricle increases wall stress. So the bigger the left ventricle, the greater the wall stress, which means there is increase in myocardial oxygen demand. And if you have a failing heart, it cannot provide that oxygen demand. If you have severe coronary artery disease, you cannot provide that demand of greater oxygen uptake. And this is how it goes. The load that you give to the heart, if it is a pressure overload, there is also an increase in systolic wall stress, increase in arterial pressure. So during systole, this increases the wall stress, so that you have ventricular remodeling by creation of parallel sarcomeres. And if you have parallel sarcomeres, you create concentric hypertrophy, where you have an increase in the left ventricular wall thickness but no increase in the diameter of the cavity, left ventricular cavity. But if you have volume overload, such as when you have rheumatic heart disease with large regurgitant volume in aortic regurgitation or mitral regurgitation, for example, this volume overload creates a ventricular remodeling with the different signals that creates sarcomeres in series. So when the sarcomeres are in series, this creates an increase in the size of the left ventricular cavity. And so, talking about wall stress, now that the diameter, now that the radius of this cavity is increased, there is also an increase in wall stress. The myocardium may not be as thick as when you have concentric hypertrophy. It's the cavity that is increased in size and increase in wall stress. So after the Frank-Starling mechanism, which discusses diastolic stretch and the contractility of the heart, the third determinant of myocardial mechanical performance is the heart rate. If you remember, cardiac output is stroke volume times heart rate. So the greater the heart rate, the greater the cardiac output. if the stroke volume is low but you have an increase in heart rate, you may be able to reach the same cardiac output. So in this phenomenon, the Bowditch staircase phenomenon, an increase in heart rate will progressively enhance the force of ventricular contraction. That was seen again in physiologic levels. So it may be different if there is already abnormality in myocardial mechanical performance. And this is what happens with heart failure. So in heart failure, you have a complex clinical syndrome that results in structural and or functional impairment of ventricular filling, which we call diastolic dysfunction, or an abnormality now in the ejection of blood, which is systolic dysfunction. So it's a complex syndrome of structural, which may also have functional impairment. So when we say structural, as we said, stretch in the myocardium or increase in the thickness of the myocardium, which will lead into either if diastolic or systolic dysfunction. Any condition that leads to the alteration in left ventricular structure or function will predispose a patient to develop heart failure. The most common etiology nowadays is coronary artery disease, sometimes called ischemic heart disease. So CAD or IHD. You need not be confused, they mean the same. No, in some countries it is called coronary artery disease. In other countries they call it ischemic heart disease. So 60 to 75% of cases of heart failure in developed countries are due to CAD. Even in our country, this is already one of the more common cause of heart failure. In our country, we still have a lot of cases of rheumatic heart disease. So it's still a common cause of heart failure in Asia and Africa. If you have obstructive lesions, such as when you have mitral stenosis or aortic stenosis, the initiating event is pressure overload. If you have regurgitant lesions, if you have mitral regurgitation or aortic regurgitation, the tendency is you have a large volume that goes back into the left ventricle. This volume overload creates the stretch that causes the structural changes, causing eccentric hypertrophy, as we have discussed before. Dilated cardiomyopathy, on the other hand, means that you have a dilated left ventricle because there has been damage to the myocardium itself. Usually it is considered as idiopathic. Idiopathic may be because you cannot clearly identify the cause. There have been viral infections that have caused dilated cardiomyopathy. It is difficult to determine. Some toxins may cause dilated cardiomyopathy. Again, difficult to isolate. Some from overdose of drugs, toxins from alcohols, toxins from or effect of chemotherapeutic agents may lead to this cardiomyopathy. And some people would mention ischemic cardiomyopathy. That is definitely wrong. There's no such thing as ischemic cardiomyopathy. Why? Because ischemic heart disease is a disease of the coronary artery, while cardiomyopathy is a disease of the muscle itself. So there's no such thing as ischemic cardiomyopathy. The RAAS system is this one area that influences the progression of heart failure. That's why we are discussing it here. So renin is the initiating substance. So renin is released by the heightened adrenergic drive. So when there is already an increase in adrenergic stimulation, this also stimulates the beta-1 adrenoceptors in the juxtaglomerular apparatus of the kidneys, thus releasing renin. Renin can also be stimulated by the activation of baroreceptors in the renal vascular bed when there is a reduction in renal blood flow or a reduced renal perfusion. As in chronic heart failure, salt restriction and diuretic treatment, which are usually our standard regimen, causes a reduction in the sodium that is presented to the macula densa of the kidneys. This is then interpreted as a decrease in circulating sodium, which contributes also to the release of renin. So with the release of renin, we see that this initiates now the conversion of an angiotensinogen, which is coming from the liver, into angiotensin 1. And by another enzyme, the ACE, angiotensin converting enzyme, the active compound angiotensin 2 is now released in the vascular bed. Angiotensin 2 may act again on the kidney to release aldosterone. And angiotensin 2 is the substance that creates most of the effect that allows heart failure to be symptomatic. Angiotensin 2 is a potent peripheral vasoconstrictor. It contributes with the increased adrenergic activity to the excess in systemic vascular resistance. And we all know that when there is an increase in systemic vascular resistance, this acts as an afterload. It causes more of the changes in the myocardium by its role in increasing mechanical strain on the myocardium, and may even have the apoptotic effect. It may cause cell death to the myocardium. Angiotensin 2 enhances the release of norepinephrine, which is also another potent vasoconstrictor, and a release of the aldosterone from the adrenal cortex. And aldosterone increases renal sodium retention. With renal sodium retention, there is also increase in volume retention, and it has also a direct adverse effect on the blood vessels and the myocardium, enhancing hypertrophy and development of fibrosis. So all of which causes left ventricular remodeling. The remodeling may start with, if you remember, concentric hypertrophy, or with series of sarcomeres, you may have already eccentric hypertrophy. Heart failure is, the terms in heart failure may sometimes be confusing. We may use the term right-sided heart failure, left-sided heart failure, systolic heart failure, diastolic heart failure. We'll try to explain and clarify all of this. Right-sided heart failure usually occur in patients with advanced left-sided heart failure. It is the most common cause of right-sided heart failure. But it may also be caused by cor pulmonale. So we may call it cor pulmonale. Cor pulmonale meaning the failure of the heart may come from the problems in the pulmonary vasculature or in the lungs itself. No? So the right ventricle fails because of the increase in pressure within the pulmonary vasculature, such as when you have pulmonary hypertension, essential pulmonary hypertension. When we say essential, it may have again no known cause. It may be pulmonary hypertension from the progression or Eisenmengerization of congenital heart disease. Again, you have right-sided heart failure there. And the manifestations will include ankle edema, hepatomegaly, ascites. So this is because of passive congestion. Even pleural effusion can develop from there. When we talk of left-sided heart failure, we're talking more of the systolic failure of the heart. That's the more common cause, especially if you have left ventricular infarction. Myocardial infarction leads to systolic heart failure. Hypertension early on may cause concentric hypertrophy and may develop diastolic heart failure first. Towards the prolongation, long period of hypertension, uncontrolled hypertension, one may develop now the long-term consequence of heart failure also. Aortic or mitral valve disease can cause left-sided heart failure. Mitral valve disease, if it is more of stenosis, you may not notice a left ventricular problem. Why? Because when the lesion is stenotic in the mitral valve, the left ventricle is preserved, the volume is in the left atrium, which causes early pulmonary congestion due to increased pressure in the pulmonary venous circulation. While mitral valve disease that involves regurgitant lesions, failure of the mitral valve to close, so the regurgitant volume increases also the volume within the left ventricle, so there is an increase in stretch of the left ventricle. With the increase in stretch of the left ventricle, you create eccentric hypertrophy, and the change, remember the definition of heart failure, structural and functional changes. The structure of the left ventricle changes, it becomes bigger, there is a increase in diameter, there is a change from the ellipsoid shape of the left ventricular cavity into a more circular left ventricular cavity, such that there is now a decrease in its contractility, increase in wall stress with the increase in diameter. So you may have the development of heart failure of reduced ejection fraction. So lately, we are now using not congestive heart failure, but to be more precise, heart failure of preserved ejection fraction and heart failure of reduced ejection fraction. So you might hear HEF-PEF and HEF-REF. And the terms are used based on the ejection fraction that is measured or estimated on 2D echo. So generally, normal would be above 50% ejection fraction. Borderline will be 41 to 49% ejection fraction, and reduced ejection fraction will be 40% and below, based on the estimates of the 2D echo. So that's why it is in percent volume of blood that is ejected during systole. Going back to diastolic dysfunction, as we said, generally diastolic dysfunction occurs with heart failure of preserved ejection fraction. So preserved, so meaning most of the time the ejection fraction is about 50% and above. So here it's more of pressure overload in the heart. So there is delayed relaxation when we are in stage 1. So when we say delayed relaxation, the left ventricle has an increase in pressure, which may be a reflection also of an increase in peripheral or systemic arterial pressure. And a delayed relaxation means there is still high left ventricular pressure such that there is a lower pressure gradient between the left atrium and the left ventricle during the diastole, such that this will have an increase in the diastolic time and may also increase the isovolumic relaxation time. That's stage 1 of diastolic dysfunction. But when we go into stage 2, the pseudonormal pattern, there is a counterbalancing effect of the delayed relaxation with the decreased compliance of the left ventricle, so that there seems to be a restoration of the diastolic time and the IVRT or isovolumic relaxation time. The stage 3 to 4 of the restrictive physiology, these are the stages usually in severe heart failure, systolic heart failure, where now there is a decrease in diastolic time and even a decrease also in the isovolumic relaxation time. Here you may have stage 3 where in the restrictive physiology may still be reversible. It's difficult to differentiate between reversible and the fixed restrictive. There is a mixture of the two. So you have both decreased diastolic time and isovolumic relaxation time. So these are usually seen as you do a 2D echo in the patient. So I hope you'll be able to see this image here. If you look at the left ventricle, the left ventricular apex is rounded. A 2D echo image in adult, by the way, is inverted. The apex is upward, while the left atrium or the base of the heart is on the lower part. So the apex is on top When it is rounded like this sample of the 2D echo image, the cavity, the apex is supposed to be the smallest part of the LV cavity so that it will allow a better ejection of the blood towards the base, because the aorta is towards the base of the left ventricle. And so a widened left ventricular cavity is a poorly functioning left ventricle. So you're very familiar now with the symptoms of heart failure, I'm sure. So very common. They will of course have dyspnea. If we look at the patient in your trigger, you have this patient with progressive dyspnea. Used to have been able to walk far, slowly having shortness of breathing, and then ultimately he began to have orthopnea, also had ankle edema, fatigue, and inability to move beyond the space of the house. No, some of the minor symptoms will be weight loss. We call this cardiac cachexia. Dry coughing is common when you already have pulmonary edema. Nocturia, palpitations. Palpitations is because the increase in heart rate tried to compensate for the decrease in cardiac output. As we said, heart rate times stroke volume is cardiac output. So with the adrenergic response, there may be an increase in heart rate to try to compensate. Peripheral cyanosis. Depression may be a part of the a decrease in cerebral perfusion. So the physical findings, again, an increase in heart rate, tachycardia, increase in the JVP. You may have a positive hepatojugular reflux as there is already edema of the liver, passive congestion of the liver. RALS. RALS is very common with mitral stenosis as a cause of heart failure, because with the mitral valve not opening fully, much of the volume is retained in the left atrium, and so the pressure in the volume will be transmitted back into the pulmonary vasculature, causing early congestion. Tachypnea. Third heart sound is a marker of heart failure. Hepatomegaly, again, part of the positive hepatojugular reflux. Ankle edema, ascites, and pleural effusion. Third spacing from increase in right ventricular failure. So as we said, mitral regurgitation may be heard not just because you have rheumatic heart disease, but mitral regurgitation may occur if the mitral valve apparatus is also ischemic, such that the mitral valve becomes insufficient. It's not able to close fully. Cardiomegaly from the increase in stretch. As we said, there may be eccentric hypertrophy with the sarcomeres in series. So, as the heart failure progresses, the dominant feature will be pulmonary congestion or dyspnea, together with the coughing, the orthopnea, the PA finding of RALS, and tachycardia. With right-sided heart failure, the dominant feature will be edema. Edema of the lower extremities. You can have ascites. You can have scrotal edema in men. And then passive congestion of the liver. So, the New York Heart Association classification of cardiac disease gives us a more objective assessment of the functional capacity of a patient. And if you review this closely, you'll be able to see how the functional capacity of your patient has progressed or has deteriorated from being able to work as a policeman towards the subsequent limitation of physical activity, so that towards the time that he was admitted, he was already unable to carry out any form of physical activity without discomfort. So this is one of the standard of making a cardiac diagnosis. You put the NYHA functional capacity of the patient. By putting there if it is class 2 or class 3 at the time that you see the patient, then the reader or the one who is reviewing your notes or your clinical data will be able to at least understand the level of deterioration of this patient. So most heart failure patients may still be, many heart failure patients may still be in the phase of compensated phase. So when we say compensated, they might not be clinically symptomatic. They may not have significant dyspnea, they may not have edema, they may not have orthopnea. But certain people become symptomatic precipitated by any of the following. So, inappropriate reduction of therapy, such as when the diuretic is reduced, when the rate controller drugs are reduced, when patients develop arrhythmia, it may trigger heart failure to become symptomatic. When a new ischemic change is noted, new infarction, a new event occurs, may precipitate heart failure in a patient who is already with significant cardiovascular pathology. A systemic infection such as pneumonia, even GI infection can precipitate a symptomatic heart failure. Pulmonary embolism causes a decrease in perfusion, decrease in oxygen saturation, and can lead to significant heart failure. Any myocardial depressant, such as a chemotherapeutic agent and salt-retaining drugs, can trigger heart failure. High output states such as pregnancy, anemia, thyrotoxicosis, these are some of the precipitating events towards symptomatic heart failure. Cardiac toxins such as boron in alcohol, chemotherapeutic agents, certain fertilizers, can be cardiac toxins. So when we think of the progression of heart failure, we look at how it affects the lungs. So that's why a chest x-ray is very important. During the first stage, there is distension and recruitment of the small pulmonary vessels. So because of the elevation of left atrial pressure, so venous congestion. So then patient develops exertional dyspnea. There may be inspiratory rust on physical examination. In stage 2, you will already see chest x-ray changes. So loss of definition of the pulmonary vascular markings. There are the curly B lines, or the thickened interlobar septa. So you will have a lot of haziness already in the peripheral pulmonary vascular markings. And when it is already in stage 3, there is already alveolar flooding. With alveolar flooding, you will be able to notice now severe hypoxemia, a decrease in oxygen saturation. There may even be hypocapnia. And so most of these patients, when they cough, it's usually pinkish or foamy blood tinge expectorate. So pinkish expectorate heralds the occurrence of pulmonary edema. So there is alveolar flooding. So that's pulmonary edema. So that's why a chest x-ray is very important when assessing the severity of heart failure at the time that patient is presented at the emergency room. So you'll also be able to notice the heart size as we assess from the chest x-ray. Usually we put it as mild cardiomegaly when the CT ratio is above 0.5 but less than 0.55. Then moderate cardiomegaly when the CT ratio is from 0.55 to less than 0.6. When the CT ratio is more than 0.6, then it is already severe cardiomegaly. The shape of the heart can tell us a lot. When the left ventricular apex is much rounded, then it speaks more of left ventricular enlargement. If you look at a lateral view and there is fullness in towards the septum, then it speaks more of right ventricular enlargement. So the size, the shape, you may be able to see changes that is consistent with left atrial enlargement. An ECG will show you if there has been a previous MI, if there is signs of left ventricular hypertrophy, left atrial abnormality, or if the rhythm is abnormal. If the patient is in atrial fibrillation, you lose the atrial systole or atrial kick, which adds to the volume that is in the left ventricle towards the end of the diastole. 2D echo is now one of our standard diagnostic tests. As we said, we define heart failure of reduced ejection fraction, heart failure of preserved ejection fraction. So that is based on a 2D echo finding. We will be able to note also if there is diastolic dysfunction based on the 2D echo. And the level of the pulmonary artery pressure can be measured also by 2D echo. The N-terminal proBNP is one cardiac marker that helps us differentiate the dyspnea of the patient. If it is cardiac, it's usually that the proBNP is elevated. If it is more of a pulmonary type of dyspnea, such as in patients with COPD or asthma, generally the NT-proBNP is not elevated. So the pro-brain natriuretic peptides are one of those cardiac markers that gets to be released when there is heart failure. So on chest x-ray, this is how a heart may be enlarged with these enhanced, prominent pulmonary vascular markings with a rounded left ventricular apex that speaks of left ventricular hypertrophy. A lateral image will also be. So there is certainly signs of pulmonary congestion and cardiomegaly in this chest x-ray. So going now into treatment. There should be a standard of care. Standard of care for heart failure patients is based on those landmark trials that have given us a guide on what these patients need, on what you can give that patient who came to you at the emergency room. This patient who had a BP of 80/50 upon arriving at the emergency room already had loss of consciousness, probably from a decrease in cerebral perfusion, or there may have been an arrhythmia to start with, which is very common with patients in heart failure. So an arrhythmia can trigger loss of consciousness. So standard of care. So based on studies of heart failure patients, the ACE inhibitors have been proven to improve the preload and afterload because of its effect on vasodilatation. Vasodilatation by inhibiting the release of angiotensin II, by inhibiting ACE angiotensin converting enzyme. Angiotensin II, the active angiotensin, does not cause vasoconstriction or even cell death. So these are some of the landmark trials that have used ACE inhibitors. Early trials used enalapril, wherein they were able to find that with this trial called the Consensus Trial, Consensus Cooperative North Scandinavian Enalapril Survival Study, which was conducted in 1987. Using enalapril, they were able to find a very significant decrease in mortality rate in severe heart failure by 40% when enalapril was compared to placebo. Placebo was the comparator then because there were no other medications that have been used in heart failure before. And then another trial using enalapril also was done in 1990. So the SOLVE trial, studies of left ventricular dysfunction, was also using enalapril, and they were able to find that there is a 22% decrease in mortality rate and hospitalization for heart failure when enalapril has been used. Another ACE inhibitor, ramipril, in the HOPE trial was able to show a decrease in the development of heart failure in high-risk patients. So when we say high-risk patients, those patients who are hypertensive, those with significant atherosclerosis, those with findings of cardiomegaly. So HOPE trial is the HOPE trial is heart outcome prevention study, which was done in the year 2000. So other modes of treatment may include the use of angiotensin II receptor blockers. So angiotensin II receptor blockers can be used as an alternative to ACE inhibitors. Most common side effect of ACE inhibition is, or the use of an ACE inhibitor is dry cough. because of the release of bradykinins. No, bradykinins are good hormones but can cause dry coughing, and some people are not able to tolerate an ACE inhibitor, so an angiotensin receptor blocker may be used. Early studies had been done using candesartan. So this is the CHARM trial, candesartan in heart failure, assessment of mortality and morbidity. This showed a decrease in mortality rate, heart failure hospitalization in patients with ejection fraction of less than 40%. So these really are the patients with reduced ejection fraction. And so candesartan has been able to show a decrease in mortality rate and heart failure hospitalization. Valsartan, with its VALHEFT study, the valsartan heart failure trial in 2002, was also able to show a decrease in heart failure hospitalization in patients with chronic heart failure. Valiant is a study using valsartan also in acute myocardial infarction patients, and it showed that early initiation of valsartan was not inferior to the use of captopril. Captopril is a short-acting ACE inhibitor. So you may start off with using ACE inhibitor or an ARB in a patient with heart failure. Another drug that's being used, one of the newer regimen for patients with heart failure, is the combination of sacubitril plus valsartan. So this is an angiotensin receptor neprilysin inhibitor. So neprilysin inhibitor, that means you inhibit neprilysin, which is the enzyme that metabolizes the natriuretic peptides, so such as nitric oxide. So why would you want to inhibit this neprilysin? You want to increase the amount of circulating nitric oxide, because nitric oxide increase or vasodilates. Nitric oxide prevents cell death. So with this drug, a combination of an ARB, valsartan, the angiotensin receptor blocker, plus sacubitril, this drug has been shown to improve heart failure symptoms, no? With a 20% risk reduction in cardiovascular death and heart failure hospitalization in patients compared to enalapril. So they compared standard of care in heart failure patient using enalapril versus this ARB plus sacubitril. They were able to still show that it may be more, it is superior to enalapril in that it has a relative risk reduction of 20% compared to enalapril for cardiovascular death and heart failure hospitalization. In fact, it has a very low NNT, no, or numbers needed to treat, of just 11 for a 5-year all-cause mortality. So this is one of the newer landmark trials that has shown an improvement for heart failure patients. So another standard of care for heart failure patients is the use of beta blockers. A decrease in heart rate will decrease oxygen demand. A decrease in heart rate will improve diastolic LV filling. An increase in diastolic LV filling will of course increase also the volume that the left ventricle can put out. But the greater effect of a decrease in heart rate is really the decrease in oxygen demand from the systolic activity of the left ventricle. So these three beta blockers, metoprolol, carvedilol, and bisoprolol, did very good landmark trials showing a decrease in mortality, a decrease in death, sudden death for patients with heart failure. All of these trials were done in patients with very low ejection fraction, less than 40% for the metoprolol trial, less than 25% for the carvedilol, less than 35% ejection fraction for the bisoprolol study. The metoprolol study, we should understand, used the long-acting metoprolol or metoprolol XR, which is succinate, is the long-acting. So this study has shown, the metoprolol trial has shown that the short-acting and the non-cardioselective beta blockers will not be able to give the same effect. So you do not use metoprolol tartrate. The study used metoprolol succinate in MERIT HF. So there is even a decrease in sudden death and death from worsening heart failure. So this MERIT is the metoprolol randomized intervention trial in congestive heart failure. So at the time that this study was done in 1999, we were still using the term congestive heart failure. Now we use heart failure of reduced ejection fraction. So same with carvedilol, a 35% decrease in death. Another study that was done with carvedilol was Capricorn in patients after MI with left ventricular dysfunction. Again, a decrease in all-cause mortality and cardiovascular mortality. So you have ACE inhibitor or an ARB. You have sacubitril or the angiotensin receptor neprilysin inhibitor. Then you have the beta blockers. And then you may also use the IF channel inhibitor. So IF channel is the phonic current, which is of the sinus node. In the sinus node, so this ivabradine is used in patients in sinus rhythm. It is not used in patients who are in atrial fibrillation. This study was able to show that the SHIFT trial of ivabradine was able to show that when you control the heart rate, you are able to decrease hospitalization for worsening heart failure and heart failure death. Again, in patients with less than 35% ejection fraction. So the SHIFT trial was conducted in 2010. This is the ivabradine and outcomes in chronic heart failure. The other trial that was done was the Beautiful trial in 2008. The morbidity, mortality evaluation of the IF inhibitor ivabradine in patients with coronary disease and left ventricular dysfunction. Again, this trial was able to decrease the AD outcome in patients with a baseline heart rate about 70 beats per minute. So the recommendation now is if you are on if patient with heart failure is on low dose beta blocker but a heart rate of less than 70 is not achieved, you may add ivabradine to be able to decrease the heart rate. So ideal heart rate will be around 60, not more than 70 for patients with heart failure. Beta blocker, you cannot push to a higher dose because you may cause hypotension. There is also a negative inotropic effect of beta blockers. So when we say negative inotropic effect, it will further decrease the inotropism or the cardiac contractility of the left ventricle at higher rate. So you can only use low-dose beta blockers in severely depressed ejection fraction. These patients with severe heart failure. So an addition of ivabradine may be able to achieve this baseline heart rate of less than 70, which decreases heart failure death and worsening heart failure. Okay, so the other drug that may be used will be the aldosterone antagonist. And as we said, aldosterone causes also apoptosis. Aldosterone may also cause patients to have sodium retention. And so, aldosterone antagonist helps to decrease the heart failure symptoms of patients. Spironolactone in the RALS trial, which is the randomized aldactone evaluation study, was able to show a 30% reduction in all-cause mortality when given with an ACE inhibitor. But when using ACE inhibitor and spironolactone or an ARB, monitor the potassium levels because spironolactone retains potassium. ACE inhibitors also retains potassium. So in patients with renal insufficiency, you have to be more cautious with the use of spironolactone together with an ACE inhibitor. That's why an ACE inhibitor is not used together with a ARB. No, so you either use either of the two but not together. So it's either an ACE inhibitor or an ARB but not together because using both increases the risk of hyperkalemia. And so you may be able to use another form of diuretic, such as for this patient who came in severe distress, improve the BP and then give the diuretic. So furosemide releases excess sodium and potassium. So it may be a good way of balancing the effect of potassium retention by the ACE inhibitors and spironolactone. So for the patient that you have in this module, we can start off with either with an inotrope to improve the blood pressure and give the diuretics. So for your standard of care, you can start the ACE inhibitor when your BP is already stable, or you can start with already the sacubitril plus valsartan combination. So not using ACE inhibitor anymore. And then by controlling also by diuresis, you may be able to decrease the heart rate as the congestion becomes lesser with the diuresis. The heart rate may be a little bit controlled, and you can continue on with the beta blocker. If the patient is not in heart failure or is not in atrial fibrillation, then an IF channel inhibitor, the ivabradine, may be used together with the beta blocker. So, putting it all together, based on the European Society of Cardiology guidelines updated in 2016, when you have a symptomatic heart failure with reduced ejection fraction, you may start with ACE inhibitor and a beta blocker. But if still symptomatic with a left ventricular ejection fraction of less than or equal to 35%, you may now use either of you may be able to use now an ARNI to replace the ACE inhibitor. So that will be sacubitril plus valsartan. If the patient is in sinus rhythm but with prolonged QRS more than 130 milliseconds, you can evaluate the patient for cardiac resynchronization therapy. Cardiac resynchronization therapy means you use biventricular pacing. When you do biventricular pacing, you put a pacemaker. Pacemaker is inserted both into the left ventricular apex and the right ventricular apex. There is reestablishment of a synchronized cardiac contractility of both the LV and the RV. That's why it's called a cardiac resynchronization therapy. You improve the synchrony of contractility of the right ventricle and the left ventricle, and it has been shown to increase the ejection fraction of patients in heart failure. If you have a patient who is in sinus rhythm with the heart rate still above 70, you may be able to use ivabradine to improve or decrease the heart rate to between 60 and 70. But if all of the above treatments combined and patient still is symptomatic, you may consider using digoxin, nitrate, ventricular assist device, or when feasible in other countries, you may have to do heart transplant. So, this again is a summary of where you are and what you can do. So, looking at our patient, the patient that has been given to us already has stage 3 to 4. You have a structural heart disease. The patient is symptomatic with shortness of breath, fatigue, and so you need to use as you first do your diuresis, then you start with an ACE inhibitor and beta blocker, or you already use sacubitril plus valsartan. So when all else fails, you may have to start with compassionate end-of-life care and hospice care. Thank you.